Our topic for this particular interview will be interpreting a PVIP scan for cardiac amyloidosis. We're privileged to have Dr. Prem Soman today, who's going to be talking with Sanjay and I about the topic. Prem has recently been appointed as the Richard S. Caligari Endowed Chair in Amyloidosis and Heart Failure at the University of Pittsburgh Medical Center. Prem is a former president of the American Society of Nuclear Cardiology and has established the Cardiac Amyloidosis Center for Excellence in Cardiology at UPMC. He's been a terrific mentor to me personally, so it's really a privilege to be here today. I'm Dr. Matt Harinstein. I'm a cardiologist, a senior vice president at UPMC International, and an associate professor of medicine at the University of Pittsburgh School of Medicine. I'm joined today by Sanjay, who will introduce himself.
Hi, everyone. My name is Sanjay Divakaran, and I'm a cardiologist and cardiovascular imager at Brigham and Women's Hospital in Boston, Massachusetts.
Thanks, Sanjay. And Prem, thanks for joining us today.
Hello, Matt. Hello, Sanjay. Hello, everybody. It's an absolute pleasure and privilege to be with you this morning.
Great. So we're really looking forward to this particular interview because I think to the membership of American Society of Nuclear Cardiology and to nuclear cardiologists in the field, this is really a topic of a high interest to them. And to learn from someone like yourself, we're very excited about it. So we wanted to start off by asking you to sort of just take us through the basics of the image acquisition protocol for a PVIP scan, if you could.
Matt, let me begin by saying that if ever there was a great example of how an imaging test has been transformative for a field, it is bone-seeking tracer scintigraphy. Let me point out that the correct terminology is cardiac scintigraphy with bone-seeking tracers. We sometimes refer to it as bone scintigraphy. Really is cardiac scintigraphy with bone-seeking tracers. And technetium pyrophosphate imaging, by virtue of giving us an ability to confirm a diagnosis of cardiac amyloidosis non-invasively, has transformed the field. It has unmasked a prevalence of amyloidosis in the community that we never imagined existed. And this unique confluence of our ability to make a non-invasive diagnosis with the introduction of therapy for a disease where none existed before has really invigorated the field. This is a great time for patients with amyloidosis, with families of patients with amyloidosis, and for all of us who work in amyloidosis. Pyrophosphate imaging has many unique attributes. It's a very simple test. It does not require any preparation. Very, very significant advantage. It can be very broadly applied to patients irrespective of body habitus, irrespective of renal function, irrespective of atrial fibrillation, cardiac devices, and so on and so forth. And it is widely available. Anybody who has a gamma camera with SPECT capability can do PVIP imaging. Now, the protocol for PVIP imaging is very nicely articulated in the ASNC practice points. It's an excellent resource for people trying to start the program or trying to expand a program of PVIP imaging. That's what we follow. We use 15 millicuries of the tracer. We only do a 180-degree orbit when we use the acquisition. We've tried the 360 degrees and we don't find it additive. We always do SPECT imaging. When we started doing PVIP scans, we acquired the images at 2 time points, both at 1 hour and 3 hours. Our experience with the 1 hour images have been excellent, as you know from our publications. The caveat being that for 1 hour imaging, and for that matter, today in 2023, all PVIP scans should be interpreted with SPECT imaging. And the 1 hour images, which are prone to persistent blood pool activity, should particularly be interpreted using SPECT. But in essence, all PVIP interpretation should be based on SPECT alone.
Terrific. Thanks, Prem. Once you have images, could you walk us through how you interpret those images for a PVIP study?
Okay. Sanjay, I'm going to show a slide here I think it would be easier to illustrate this with a slide. And I'm starting with the planar views, but again, I'm going to emphasize, that I often wonder whether we even need planar images for pyrophosphates interpretation, and all diagnostic interpretation should be based on SPECT, but we do planar images. And in addition to the anterior and lateral views that are widely performed, we also do the LAO view. And you can see here in this image here on the LAO view, RV uptake of pyrophosphate can be very nicely demonstrated. And I think there is increasing data now, particularly looking at strain analysis and so forth, that RV involvement has prognostic significance in patients with TTR amyloidosis. Now, as I said, the interpretation should be, the diagnostic decision-making should be entirely based on SPECT images. And when I teach PVIP interpretation, I make it a point to say that an unequivocally positive PVIP scan looks like a normal myocardial perfusion scan with MIB or thallium or tetraphosphate. And this is because the diagnostic standard is the demonstration of diffuse uptake of PVIP in the myocardium. So as you can see here, if I didn't tell you that this was a PVIP scan, this could very well be a MIB scan, a normal MIB scan. So when a PVIP scan looks like a normal myocardial perfusion scan, then it's an unequivocally positive pyrophosphate scan. Now, if you see some sort of tracer uptake in the field of view, but it doesn't look like a normal myocardial perfusion scan, that's when you need to step back and reassess to figure out what's happening. So you see the difference between the top panel and the bottom panel. And when it does not look like a normal myocardial perfusion scan, you step back and reassess. And what do we do when it does not look a slam dunk positive scan? We look very carefully for blood pool activity. We go back to the patient to figure out what the pre-test probability of TTR amyloidosis is. Was it the patient who was referred just because of LVH and heart failure, for example, or was it somebody who had bilateral carpal tunnel, somebody who had spinal stenosis? Is it an asymptomatic carrier of a gene abnormality? So we look at the pretest probability. We look at CMR and echo strain at that point if they're available. Sometimes we've repeated the PVIP after a few months. But in all cases, it's really important to make sure that AL amyloidosis is excluded. Now, I will also say that because SPECT imaging is relative intensity of traces, based on the relative intensity of the tracer. So it is my belief that when you see a lot of extramyocardial uptake, it probably means that there is not avid myocardial uptake. Usually when you see a lot of blood pool uptake, that also means that there is not enough uptake in the myocardium to suppress the extracardiac uptake. We recently looked at this systematically. Brent Medhoff, who was a former amyloid fellow and now is a cardiology fellow with us, looked at all the PVIP scans over the past several years that we had interpreted as equivocal. And there were about, I think, 23 scans that we had actually formally reported as equivocal. And when we looked at what happened to these patients, not a single one of them actually had a final diagnosis of cardiac amyloidosis. And it's very interesting that when you look at the profile of these patients, the profile of these patients more closely aligned with patients who had negative PVIPs than positive PVIPs. So, this is not an infallible rule, but I do think that, when you see a lot of extracardiac uptake, that probably means that there is not intense myocardial uptake.
Those are great images, and I think very helpful for us and for people to see, how you go about that initial diagnosis. How do you score a pyrophosphate scan, and what are some of the confounders you see when you're trying to make that determination?
Yeah, Matt, we don't score the PVIP images at all. Our interpretation is completely based on SPECT. We do not report the Perugini score, which is the semi-quantitative scoring of the planar images compared to rib uptake. And we do not report the heart to contralateral ratios. We've never reported them. By the way, the HCL ratio stands for heart to contralateral ratio. I called it the heart to contralateral lung ratio for the longest time until one day I was speaking to Sabahat Bukhari, who proposed the term and said, we intended it to be heart to contralateral ratio. So I heard it from the most reliable source, if you will. So it is heart to contralateral ratio. So our interpretation statement says there is diffuse myocardial uptake on the SPECT images. This is suggestive or highly suggestive of TTR amyloidosis. Now, you could turn around and ask me why we do the planar images, and I increasingly ask myself that question. One is habit, right? We start off with the planar image and move to the SPECT image, and I think it's useful for the technologists to prepare for the SPECT images when they know that the planar image is positive or negative. Second is, if the SPECT images are equivocal, then not seeing any uptake on the planar scan or seeing grade 2 uptake on the planar scan is sometimes helpful in interpreting the SPECT images. Now, our understanding of PVIP imaging and its application to patients has evolved over time, and so there may come a time when we don't use planar imaging. We're not there just as yet.
Great. Prem, to build on this last point in terms of the final interpretation of a PVIP study, you're not only a master cardiovascular imager, but you're also a master clinician. So how do you use these results clinically?
Yeah. The first and perhaps the most important point in all of this is to make it very clear in your report that AL amyloidosis has to be excluded. Even in labs whose only function is to report the scan, right? Even if it's a referral lab where the patients are not being seen by the interpreters, it is the responsibility of an interpreter to alert the physician to the fact that PVIP scintigraphy does not exclude AL amyloidosis. So we have a statement in our report which says that pyrophosphate scintigraphy does not exclude AL amyloidosis. So, and we list out the complement of tests that should be performed to exclude a paraprotein, and we say that those tests should be performed and the PVIP scan interpreted in conjunction with those studies. And of course, that statement is applicable both to positive and negative PVIP scans.
That's great. And thank you for telling us about the HCL and your experience with that. But what are some of the common missteps you've seen in PYP interpretation and reporting from other labs or from others, and how would you go about trying to recommend how to get back on the right track?
Mm-hmm. So this is a very important question, Matt, because we have moved from applying the PYP scan to high probability patients and expert centers to now sort of as a community screening tool. It is important to remember that the performance characteristics of PYP were tested really in very expert centers in patients with a high pretest probability of disease. And we don't quite know yet how it performs when you apply it in patients with lower pretest probability and in the community. Now, I would emphasize three important areas where mistakes happen. Number one is the failure to exclude AL amyloidosis, and I think this is worth emphasizing. The most important step in the evaluation of a patient with suspected amyloid, whether you are coming at this from an image interpretation standpoint or whether you're a clinician taking care of these patients, perhaps the most important step is to exclude AL. A diagnostic mistake there has really, really dire consequences. Now, I also think that it's worth remembering or recapitulating that the complement of tests that most effectively exclude a paraprotein, and when I say a paraprotein, we're really talking about AL associated with multiple myeloma or primary AL amyloidosis. The best complement is the following. It's the serum free light chain numbers, the values, and the ratio, and urine and serum immunofixation electrophoresis. The standard protein electrophoresis, which is a quantitative test, is not sensitive enough to alert us to the presence of a paraprotein. Actually, the serum immunofixation is about 50 times more sensitive than the standard protein electrophoresis. So if we perform these three tests, 99% of patients with a paraprotein will have an abnormality in one or more of these tests. So the most important, perhaps, aspect of this process of evaluating somebody is to exclude AL amyloidosis. Now, an important question is, should we not do a PVIP unless the AL screen is done? And should we not interpret a PVIP scan if the AL screen is not available? So this is where what's ideal, you have to marry what's ideal with what's pragmatic. Most physicians who refer patients for PVIP will also order the serum labs. In our EPIC order sheet, as you know, Matt, when you place an order for a PVIP scan, the order for the serum studies automatically pop up, and it is ordered. But very often patients will land up in the lab not having yet done the PVIP scan. So we look for the not having yet done the AL screen. So when we interpret the PVIP scan, we look for the AL labs. If it's present, that's useful. If it's not present, we have the statement that alerts the physician to the fact that they should absolutely perform. So that's the first point where mistakes are made. The second point, of course, is making sure that the positive scan, and here I'm alluding to the planar scan, the positive planar image is really due to myocardial uptake and not persistence of tracer in the blood pool. A lot of the older studies, I feel, were confounded by planar images that showed blood pool uptake. I will mention in this regard that I do think that the statistics on positive PVIPs in AL amyloidosis, I would argue that we really don't know what the true prevalence of a strongly positive PVIP scan is in AL amyloidosis. I've seen anecdotal reports of positivity, grade 1, grade 2. Personally, we have not seen here a truly positive grade 3 uptake on SPECT in AL amyloidosis, and a lot of the prior studies are based on planar images. And so it is really, really important to use SPECT imaging. And if you have SPECT CT, that is of great advantage in differentiating blood pool uptake from myocardial uptake. If I can show you a couple of slides here, which I think are useful. A lot of this is to do with pattern recognition. So here is a planar PVIP scan that looks sort of positive. And in the coronal view, when you look at the SPECT images, remember what I said. The first step is, does this look like a normal myocardial perfusion scan? And it doesn't. In fact, it looks like a radionuclide ventriculogram. It looks like a MUGA scan. And this is a typical example of what looks like a positive scan, but this is not because there is tracer in the myocardium. This is because of persistence of tracer in the blood pool. And this is a negative pyrophosphate scan. Now, again, in terms of pattern recognition, if you do a SPECT, a chest SPECT acquisition, so when we do the reconstruction, if the planar images look negative, we perform a SPECT reconstruction, which means the limits are expanded to go from the base of the neck to up to the diaphragm. And we don't reorient the SPECT images to the standard cardiac, the short axis and the long axis views. So if you do a chest SPECT in the transaxial view, a truly positive scan has the appearance of this complete horseshoe here. Do you see that? A complete horseshoe where you can also see the apex. And this is, again, the typical image of a truly positive scan. Whereas here it appears that there's myocardial uptake, but you don't see the apex. And this is a tracer in the left and right cavities. Now, again, like every test, you have to interpret this in the context of the clinical situation. I'm talking about unequivocally positive, strongly positive scans. Early positivity and patchy uptake are things that one has to always keep in the back of the mind. Now, as I said, that is with the interpretation, the SPECT interpretation. As I said, if you have SPECT CT, the SPECT CT, because of the anatomical localization with the CT, is very useful to differentiate blood pool activity from myocardium. But as you know, SPECT CTs are not that widely available, and most laboratories that do PVIP scintigraphy do not have SPECT imaging, so do not have SPECT CT equipment. So we have implemented something that was first described by Dan Berman's group, and that is to use a small dose of thallium as a perfusion tracer to derive myocardial contours that can then be applied on the PVIP image. Now, this requires a CZT, a solid-state camera. And the need for a solid-state camera is because solid-state imaging, because of its much better KEV discrimination, allows dual isotope imaging with thallium and PVIP. As you know, thallium is about 80 keV and technetium is about 140 keV. So you can inject both tracers and then set the two windows of acquisition and acquire a simultaneous dual isotope study. This allows the contours derived from the perfusion scan to be seamlessly and accurately applied to the pyrophosphate scan. We started doing that in everybody, and now before thallium became unavailable, we settled to using this for patients selectively who have equivocal scans. So most of our PVIP scans are done on a standard anger camera. We do the planar imaging and the SPECT imaging. If it's unequivocally negative, we are done. If it's unequivocally positive, we are done. If it's equivocal, we inject 1 millicurie of thallium and then quickly, in 5 minutes, do a simultaneous dual isotope acquisition. So here is an example of a patient who has a truly equivocal scan. You look at the scan, the planar scan shows some uptake, the SPECT image shows some tracer activity in the field of view. It's impossible to define whether this is in the cavity or in the myocardium. So we inject 1 millicurie of thallium, do a simultaneous dual isotope uptake acquisition, and on the top panel are the myocardial contours derived from the thallium perfusion scan. And you can see when we apply these contours to the pyrophosphate image, you now very, very clearly see that the uptake is in the cavity and not in the myocardium. In fact, in our series of a number of patients, we found that the application of the dual isotope technology completely eliminated equivocal scans in our lab. And unfortunately, soon after we implemented this, thallium, as you know, is now not available, so we can't do this. Now, this application of 1 millicurie of thallium increases the radiation dose by about 7 to 10 millicuries, if I remember correctly. And you have to balance that additional radiation dose with the possibility of avoiding a biopsy under fluoroscopy. So there is the radiation associated with fluoroscopy and the small but definite risks associated with a biopsy. And we find this very, very useful. So to go back to your question of the potential pitfalls and failure modes, I talked about always excluding AL. Number 2, always making sure that the uptake is on the SPECT. And the third is what is applicable to any form of imaging, right? If the clinical features and if your clinical impression does not corroborate or conform to what you're seeing on the image, further testing is necessary. Our threshold for myocardial biopsies is relatively low. As you know, interpretation of the serum studies, especially in older people, it's not always positive or negative because of the prevalence of MGUS and renal failure and so many other things that affect interpretation of the serum studies. And it's also important to remember that we are recognizing certain gene mutations like the P65 leucine mutation, which because of the fibril composition may be associated with a negative PVIP scan. So the third point I want to make is that if the clinical findings, other imaging findings do not match the PVIP, you need to do more testing and a biopsy if necessary.
Prem, that was really extremely helpful. And I think for those who are watching this interview, you really gave some great tips as to how nuclear labs can set up a program. It's not just the imaging component, it's factoring in how you use that imaging and how you relate it to the clinical component and adding in those order sets and things like that that can be helpful to running a program, not just the imaging component. So that was extremely helpful for all those who are watching. So overall, this was really a terrific overview from an expert in the field on how to how to interpret a PVIP scan, and certainly it was a privilege for me to have a chance to speak with you today, and Sanjay as well.
Thanks so much, Prem. This was wonderful.
Thank you, Matt. Thank you, Sanjay. It's such a privilege to do this.
Thanks very much. We appreciate it.